ايش الجمال هذا دكتور هاني، الله يخليهم ويحفظهم.
الله يخليكم، شكرا. طيب can we start؟ تبغوا نستنى دقائق؟ شايف ناس كثير خرجت ولا انتوا قفلتوا البرزنتيشن وشعتوه ثاني؟
هو قفل اللينك ويحتاج ندخل مرة ثانية بس.
طيب طيب يلا نبدأ. بسم الله. انتوا بتسجل برزنتيشن المفروض تكون متسجلة. طيب واضحة البرزنتيشن؟
ايوه دكتور.
نعم واضحة.
بسم الله بسم الله بسم الله بسم الله توكلنا على الله. Okay, so today inshallah we'll talk about tetralogy of fellow. Again, some embryology, anatomy, pathophysiology, natural history, presentation, management, conclusion, and questions. So tetralogy of fellow is the most common form of cyanotic heart disease. It occurs in approximately 1 in 3,000 births, so it's not that uncommon. And it's the more 10% of congenital heart disease. It's also the most common congenital disease requiring surgical correction in the first year of life, without which only 10% of patients will survive up to the age of 30 years. So 1 year mortality without full repair is around 30%, and 10-year mortality is around 50%, and 90% mortality at 30 years without full repair. It was first described in the 19th century by Arthur Fowler. That's why it's called tetralogy of Fowler. It's a tetralogy because it's 4 things. So it's just, as you guys know me, and I like embryology. So, you know, there you have the cardiac tube, and then what happens and what makes tetralogy a tetralogy is at the 23rd to the 25th days of life, the infundibulum of the RVOT does not connect to the pulmonary artery in the correct way, so it gets elongated. So the 5th week of life, pairs of opposing ridges appear in the truncus. They connect, hence while growing towards the aortic sac, and swelling twist around each other, and foreshadowing the spiral course, which is the normal course of the aorta and the PA. And this is just another depiction of how does the aorta and the PA twist. It's like a helix, and that's what makes septation of the conus. Anatomically, abnormal neural crest cell migration. So some people consider tetralogy as a conotruncal anomaly, although it's not truly a conotruncal anomaly, but with an anterior displacement, not posterior. This is anterior displacement of the aortopulmonary septum, and that leading to unequal division of the truncus, which leads to pulmonary stenosis, right ventricular hypertrophy, overriding of the aorta, and ventricular septal defect. The pulmonary stenosis happens because of the stretch, the distance that the chorus has to travel to the PA to connect. The right ventricular hypertrophy is a function of the pulmonary stenosis. The overriding of the aorta is because of the VSD is posterior anterior alignment, and the ventricular septal defect is one of the things that, subhanallah, is there to keep the baby alive.
Dr. Hani,
this is just another picture.
I've read another hypothesis. I think it's Van Braag hypothesis. State, and that said that's the origin of the tetralogy of Fallot is hypoplasia of the pulmonary artery itself, or the root of the pulmonary artery, which pulls the truncus septum anteriorly. Right?
This is another hypothesis, although the only problem with hypoplasia hypothesis is that there's always a pulmonary valve. So people, there's no right or wrong here, but the Van Praagh is an extreme form of tetralogy where there is a total occlusion of the pulmonary valve. So this hypothesis is the common one that we see in every day. VAMPRA is not wrong, but it's an extreme form of tetralogy where they are very severely cyanotic. No one will ask you about pathology, embryology in the exam, not you guys. Maybe for fellowship questions, but not for you guys. But this is the common one. The VAMPRA classification is a bit different, but this is the common accepted one. So 1 month old, poor feeding and gets blue when she cries, presents to the ER because she's crying, got very blue and had a seizure. So if you guys look at the echo, the loops are very fast, I'm sorry, but see here there's turbulence at the pulmonary valve level. The RVOT is very long. Usually the valve is a bit closer to the annulus, to the RVOT origin. This RVOT is very long. There is a VSD, which is anteriorly shifted. There's a gradient across the pulmonary valve. So the diagnosis was tetralogy of Fallot. So genetic syndromes are identified at least 20% of tetralogies. The most common is DiGeorge, which results from one of several known deletions, but the most common one is chromosome 22, which is 22q11. So there is an association between tetralogy and interrupted aortic arch. 20% of tetralogies have genetic defects. So trisomy 21, Bactrel, DiGeorge syndrome. In reality, tetralogy is made up of two main abnormalities. Basically, a huge VSD with equalization of pressure and RVOT obstruction. RVH is a secondary finding. Due to RVOT obstruction, the VSD in tetralogy of Fallot is large perimembranous defect with extension to the subpulmonary region. So it's two VSDs, not one. So it's a perimembranous with outlet extension because of the stretch. So the VAMPRA theory does not explain why the VSD is like that. So that's why I can't remember who came up with this theory, but this is the common one that people actually accept. The RVOT obstruction is most frequently in the form of infundibular stenosis because of the distance between the infundibulum and the pulmonary artery are so far. The muscle needs to stretch the tube that connects the infundibulum to the pulmonary artery, which causes a narrowing, hypertrophy of the muscle. The obstruction is less commonly at the pulmonary valve level, although it's not unheard of. It's not unusual to have a bicuspid pulmonary valve with tetralogy of Fallot. A combination of the two is common, it's 30%. Pulmonary valve is atretic in most severe forms. It's only 15%. So the VAMPRA theory only explains 15% of all tetralogies. Because of the VSD is large with an area about as great as the aortic valve, both ventricles and the aorta have essentially the same systolic pressures. But because of the RVT obstruction, there is RVH. The most important hemodynamic factor is the ratio between the resistance to flow into the aorta and the resistance to flow into the right ventricle, infundibulum. If the stenosis is not that severe and the resistance into the right ventricular flow is not too large, meaning that there's no pulmonary hypertension, the pulmonary flow may be more than twice the systemic flow, and the arterial oxygen saturation can be as close as to normal. So that you can have a patient who has severe RVT obstruction, but they are not cyanotic because they have low pulmonary pressures. However, the resistance to pulmonary artery flow may be increased markedly, causing right to left shunt, arterial desaturation, and subsequent polycythemia can happen, which happens when the baby is crying. When they are crying, they increase the intrathoracic pressure, and then they create acute pulmonary hypertension, which because of the VSD is just sitting under the aorta, then the shunt gets reversed from left to right, right to left, and they get cyanotic. So that's what happens when you have dynamic obstruction. So drug, heart rate, our maneuver to increase myocardial contractility or decrease right ventricular volume, increase infundibular obstruction. So tachycardia, exercise, right ventricular volume, or dehydration can cause cyanosis. In addition, infantile hypertrophy may increase gradually over time because of the RVH, because of the stenosis, which causes hypertrophy of the infundibular muscle. As the systolic pressure in the right ventricle cannot exceed the left ventricular because of the large VSD, the right ventricle is protected. So it's like an auto band. They are banded from excessive pressure and work. So heart failure is really uncommon. So if a tetralogy comes with heart failure, then they are most likely do not have severe RVOT obstruction. It's very common to have other associated anomalies. So right aortic arch in 30% of them, anomalous origin of the LAD and RCA is not uncommon, 10%. Second MASD is 15%, and persistent left SBC is also 10%. With infant with acyanotic tetralogy gradually become cyanotic over time. Patients who are already cyanotic become more cyanotic as the infundibular stenosis worsens and polycythemia develops. Polycythemia is a secondary effect of the chronic cyanosis they develop. Development of relative iron deficiency anemia is not uncommon, and hypoxic spells may develop in infants. They have, most of them will have growth retardation is directly correlated with severity of cyanosis. Brain abscesses and cerebrovascular accidents rarely occur. Endocarditis is a very bad complication to have in a tetralogy patient. And some patients, particularly those with severe TET, develop aortic regurg because of the location of the VSD. Coagulopathy is a late complication and long-standing cyanosis. They usually present with asymptomatic until they become cyanotic. Dyspnea, exertion, squatting, or hypoxic spells develop later in mildly cyanotic infants. Occasionally, infants with acyanotic tetralogy flow may be asymptomatic or may show signs of congestive heart failure with a large left to right shunt. And these are the patients that have mild RVOT obstruction or no RVOT obstruction, basically. The typical chest X-ray finding is a boot-shaped heart. Basically an elongated RVOT, which takes the hump here that we see for the pulmonary artery. And the heart is, because of the RVH and RV dilatation, then the heart becomes pushed to the left side. So what is the cyanotic spell? Are characterized by paroxysms of hyperapnea, which is rapid and deep respiration, irritability and prolonged crying, increasing cyanosis, and then decreasing intensity of heart murmur. So if you get a tetralogy in a cyanotic spell, you put your stethoscope on the chest and you hear no murmur. Once you stabilize them, then you hear the murmur that comes back to be comes again and becomes very loud. And the reason is because when they're in a cyanotic spell, the shunt is actually either reversed or there is no shunt. So when the murmur is coming towards the stethoscope, you can hear it. When it's go away from the stethoscope, you cannot hear it. These spells are usually occur in the morning or after crying, feeding, or with Valsalva maneuvers, like when they try to poop. Cyanotic spells occur in infants with a peak incidence between the 2nd to the 4th month of life. Severe spell may lead to limpness, convulsion-like symptoms because of the severe hypoxia or stroke or even death. So a child with a TET, with tetralogy, you will have typical spell when they have blue lips, blue hands, and blue feet. The mother will never tell you that the whole face was black, but the lips were very, very dark. So unfortunately, it's a vicious cycle. So it's increasing PVR. So the baby will start having increasing PO2, increasing PCO2, decreasing pH, hyperapnea, then systemic venous return will increase. The spasm in the RVOT will increase, the SBR decrease, more crying until they lose consciousness. So medical management is very important. So you have to educate the parents how to deal with the cyanotic spell, during infancy. That's very important because there are so very small, simple maneuvers that they can do to save the baby's life. So squatting, calming the baby, putting them on their belly, decreasing the noise, and medications also, but the medications takes a while. So beta blockers, especially propranolol, is the drug of choice for patients who have frequent spells to decrease their heart rate and decrease the number of spells. It does not prevent totally spell, but it decreases the number of spells and the duration of the spell. The management of tetralogy is basically surgical. There's no role for intervention here, but the surgery can be twofold, either palliative procedure or a corrective procedure. Before we move on, we need to remember that there is so much variability of the anatomy of tetralogy. So VSD can be outlet or doubly committed. Pulmonary valve can be normal, but rare, severely fibrotic, thickened, absent, bicuspid. RVOT obstruction can be fibrous versus muscular. RVOT can be long or short. Coronary anomalies are not that uncommon, especially RCA crossing the RVOT, which dramatically affects your surgical approach. Branch pulmonary arteries can be large or very small. So this surgical management is dictated by the variability. So this is a picture of the on the left side of from left to right is Alfred Blalock, Vivian Thomas, and Helen Tossing, who were the first people to describe how to manage these children. Blalock is a pediatric surgeon. Vivian Thomas is actually his lab technician, and Dr. Tossing is a pediatric cardiologist who was the first female pediatric cardiologist in Harvard, who was assigned to the blue baby ward because she was a female and they didn't want to deal with her. And these are dying kids, so she basically invested her time and life for these kids. And then this is the first procedure that was done in Harvard of a BT shunt, Blalock to Soshang, or it should be called BTT shunt, for this baby through a left left thoracotomy. And that's here standing, that's Alfred Blalock, and this is Vivian Thomas telling him how to do the procedure because he did it in the lab on dogs. So shunt procedures are performed to increase the pulmonary blood flow in a child who has significantly low blood flow to the pulmonary circulation. The indications now are very limited, but it mainly indicate for neonates with tetralogy and pulmonary atresia, infants with hypoplastic pulmonary annulus, children with hypoplastic pulmonary arteries, unfavorable coronary artery anatomy, infants with younger than 3 to 4 months, although this is not true anymore, medically unmanageable hypoxic spells, and an infant weighing less than 2.5 kg. So a BT shunt is basically a classic BT shunt was done through the left thoracotomy. Basically, you transect the subclavian artery and bring it down to the LPA. Modified BT shunt is basically, instead of using the subclavian artery as itself, you take a Cortex tube and connect it to the pulmonary artery, which side you want. This can be done through a thoracotomy or a median stenotomy. There are different shunts that you guys will hear about. Not a lot of people use them anymore for TET. There are different indications now, but there is something called the Watterson shunt. Basically, you take the posterior wall of the ascending aorta just above the STJ and connect it to the RPA, which is basically behind it. This is the direct end-to-side anastomosis or side-to-side anastomosis. And there is also a Potts shunt, which takes the descending thoracic aorta anterior wall connected to the posterior wall of the LPA. Nowadays, with good interventional cardiologists, the PDA can be stented in these patients who have cyanotic spells. That's an option that can be considered in these patients that have TET spells that you don't want to take to the OR and put a BT shunt and deal with the complications of the BT shunt. This is a nice paper that compares between PDA stenting versus BT shunt, and basically it shows that both of them are equal, but PDA stenting has better short-term outcomes and less complications compared to the BT shunt. So if you have an interventional cardiologist that is willing to do these stents, then this should be your first modality of treatment in a cyanotic sick histology patient, followed by a BT shunt. So 7-month-old boy, poor weight gain, tachypnea, no history of cyanosis, new diagnosis of histology of flow. So that's the echo. Basically a large VSD with a left to right, right to right, left shunt, wide open arch, a small PDA here. And there is a lot of turbulence, but the good thing here is that if you guys see that the stenosis is valvular, it's not infundibular. So the infundibular is elongated, but it's not hypertrophied. And that's why this baby is not cyanotic, because it's a valve problem, not a subvalvular problem. If they have subvalvular obstruction, then it's they're usually cyanotic. Again, the VSD. Okay, so this is in the cath lab. If you can see that it's just a pure valve stenosis. This infundibulum is actually huge. This is the stenosis, just at the valve level. So this is post-operatively. You can see a VSD patch. Here, this is the aorta, the VSD patch. Okay. All of these echoes, when you look at them, you think that the crux of the VSD will cause LVOT obstruction. Alhamdulillah, this doesn't happen. And then the LVOT remodels after 6 months, and the VSD crux gets more deviated back to the right side. So complete repair is the biggest debate when to repair, and the tough. Should symptomatic neonates and infants below the certain age of size be palliated before complete repair, or should just have primary for repair? And when should acyanotic neonates and young infants should be repaired? So there are people who are pro early complete repair versus late repair, and early versus late is before 6 months of age and after 6 months of age. So the pros are avoid longer periods of cyanosis that might cause neurological deficits, decrease right ventricular hypertrophy, pulmonary alveolar development, can be adversely affected by prolonged cyanosis, and any palliative procedure may multiple procedures. The cons are reported increased morbidity and mortality, higher rate of pre-intervention, risk of pacemaker is higher, significantly higher, and higher rate of transannular patch, at least 50%, and around 90% in neonates with less than 1 month, and higher use of homographs. So if you consider delayed complete repair, and that's 3 months of age, higher rate of successful repair, higher rate of transatrial approach, smaller ventriculotomy, less arrhythmias, better RV function, higher rate of pulmonary valve preservation. The cons are stressful for the parents because they have to wait with a cyanotic child. A child might be mildly cyanosed for long periods, and the question is about brain development. And when a cyanotic spell happens, it's a very dramatic experience for the family, especially for the first time. Shunt in tetralogy for stage repair. So some centers do shunt all of these children. So it ensures pulmonary blood flow, growth of the branches is guaranteed. Dilated the pulmonary valve annulus because of the retrograde flow, which decrease the likelihood of transannular patch and less likely to have cyanosis. The cons, difficult surgery in sick neonate. BT shunt has high complication rate, 3 to 10%, and morbidity up to 25%. Distortion of the pulmonary arteries, which might require extra surgical work and complete repair, and it's a redo surgery, so it comes with a price. what if there's no BDA and modified BT shunt is risky? So it's described that the RVOT stenting is a good option, but it dictates that the child will have transannular patch, because at the time of surgery, when you go to do the full repair, you have to remove the stent, which basically destroyed the pulmonary valve. So sometimes it's difficult to remove because they are very embedded. So most literature will advocate repairing these children within a month to 6 weeks from the stent. So you don't have full ingrowth of the stent into the pulmonary artery wall. So 3-month-old diagnosed at birth with tetralogy, average saturation is 88 in room air, growing well, no cyanotic spells, on propranolol. Again, very large aorta, small PA. LPA is a bit smallish, hypertrophied RV. There's infundibular, and so PA looks very small here. So we took him to the OR. This was around the age of 4 months. Did tetralogy of physiology flow repair, a small VSD patch. And then we did monocusp repair. So we augmented the bicuspid pulmonary valve, made it tricuspid. So that's the monocusp. Basically, the whole idea is just to prevent PI. You cannot ever have zero pulmonary leakage. The gradient is 3, so that's good. There's no stenosis. But there is always PI, but you're changing it from a full-blown severe pulmonary leakage into mild to moderate. And the whole idea is to prolong the time that you need to re-intervene surgically in the future. So surgical tips. So it's a regular, bicaval cannulation, ascending or distal ascending aorta. You open, you expose the tricuspid annulus. VSD is always below the tricuspid annulus, but you have to remember that this is premembranous to outlet. So there's a component of the VSD that you cannot see very well without pulling up. You resect the parietal extension of the infundibulum. So that's the RVOT obstruction. So you always resect towards between 1 and 3 o'clock. Never resect close to you, because these are muscles that are actually attached to the annulus, the pulmonary annulus. And if you do that, you basically thin the annulus and increase the incidence of severe leakage. And most of the time the hypertrophy is anterior, is not lateral. So you resect this muscle, resect as much as you can safely, and be aware of conduction tissue, which is usually posterior in the VSD. Do not go crazy in resecting anteriorly, because sometimes you can thin out the muscle, perforate the RVOT. But that's not a bad thing. It's not a big deal if you do that, because you have to open anyway, but it just extends your RVOT incision if you perforate mid RVOT. I usually tend to open the PA above the valve and the RVOT and look at the valve from up and below. The RVOT incision here helps you to do as much RVOT resection as possible. You take a patch. If you do transannular, you take a big patch and cover the opening. If you do a double patch technique, basically you augment the MPA. You always have to augment the MPA. There's no point of just augmenting the RVOT, because there's always some level of underdevelopment of the MPA. And you augment the RVOT with another patch. Sometimes you have to do commissurotomies for the pulmonary valve. So this is again how to close the VSD. Again, these are like any VSD. The conduction system is usually posterior, but because the VSD is large, it's usually closer. So your stitches on the posterior from the surgeon side between 6 and 9 o'clock should be away from the edges. This is another case. large VSD, see posterior malalignment, sorry, anterior malalignment of the VSD, the aorta is almost under the VSD. We did again monocusp, and I like to do monocusp for tetralogies. Here basically there's no regurg, so the monocusp is doing the job. This is another case where we did valve sparing, so the valve looked perfect. There was nothing wrong with the pulmonary valve. So we just did RVT patch and MPI patch and JT closure. So mortality is low, but 2 to 4%, regardless of the age of repair. Morbidity is dependent on many factors: age of repair, severity of cyanosis, associated syndromes, pulmonary valve morphology, and surgical experience. Is transannular patch bad with free pulmonary insufficiency? So for survival, no, but from they are almost equal. So there is no increase in mortality or anything. The problem usually is that the risk of reintervention. So if you have a valve sparing versus transannular patch, your risk of reintervention is much higher in the transannular patch group versus the valve sparing. The valve sparing usually need more interventions, but in the future, but they almost all can be dealt with by interventional cardiologists, mainly branch pulmonary artery stenosis. The long-term results of early primary repair and tetralogy of flow are excellent, and freedom of reintervention satisfactory after early primary repair, which is within the first 3 months of life. Using transannular patch does not reduce the survival and associated with lower incidence of ventricular outflow tract obstruction. So for a small baby, usually people are forced to do transannular patch because of the size discrepancy. So what the issue with transannular patch? So it's free PI, which causes progressive RV dilatation, decreased RV function, arrhythmia, and poor quality of life. So a 24-year-old male, non-tetralogy of flow, unrepaired because parents refused surgery long time ago, presenting with syncope and cyanosis, shortness of breath and palpitation. He wants to repair now, so we took him to the OR and did tetralogy repair with valve sparing. This is VSD. You basically can see here in the VSD that is basically the ventricular septum is sitting under the aorta. So it's not, I've never seen anything in my training, but this is like my first case in Saudi Arabia. So here you will see, if you do congenital, you'll see these cases. So can tetralogy survive without repair? Yes, but they will be very symptomatic, mainly at around the age of 30. They can develop severe complications, growth retardation, below average IQ, clubbing, liver congestion, and RV failure. This is the monocusp I was talking about. Basically, you create a huge anterior cusp that closes the in diastole and prevents PI. There are other techniques, but this is the simplest. You can use autologous pericardium or bovine pericardium. So in conclusion, tetralogy is the most common cyanotic heart disease associated with some congenital anomalies, very low mortality. Surgical repair is the only treatment. Some children require early intervention. Transannular patch has good long-term outcomes, and most of these children will need intervention in the future. Questions?
Thank you, Dr. Hani. If you allow me, I have 2 questions. If you are doing valve preservation, do you still need to do RV augmentation or no? If you are not doing transannular patch, you still do RV augmentation or not? This is one question.
Yes, you have to do RVOT. You have to do RVOT augmentation because that's the pathology. If they don't have, even if they don't have RVOT obstruction, by closing the VSD, you can create some gradient across the RVOT. and then you are in trouble. So it's always advisable even to put just a small patch. Anyway, you have, as part of tetralogy, you have to do some resection of the crossing muscle in the RVOT. So might as well do RVOT augmentation. And I always do, just routinely do it, because once they go out and then they come back in 6 months with RVOT gradient, there's nothing they can do in the cath lab to fix that part. The PA can be dilated, but the RVOT, they have nothing to do. So it's always advisable to do some RVOT augmentation.
Okay. طيب دكتور, in terms of anomalous coronary artery, is there a major change in the technique, or just identifying, or?
Yes. No, so if you have an RVOT, so the most common congenital anomaly, coronary anomaly with TET is an RCA crossing the RVOT, coming from the left, crossing the RVOT, anterior to the RVOT. So that if that's there, then you cannot do a transannular patch. And sometimes, because of the severity of the pulmonary valve stenosis or the pathology itself, then you have to do something to deal with the valve level obstruction. So, and I only had one case in my life to do something like this. We had coronary artery anomaly, huge RCA basically crossing the RVOT. And we had to do a double barrel technique. Basically, a double barrel technique, you do an RV to PA conduit from the RVOT opening to the distal to the MPA, and you're creating two lumens basically for the RVOT. You don't do anything to the pulmonary valve, you leave it alone, but you put an RV to PA conduit.
Okay, clear. Thank you, Doctor.
Assalamu alaikum, Dr. Hanim. Just one more question about those patients with anomalous coronaries. If you have a small patient who already has, for example, the duct is closed, so they can't stent the duct or anything, and the patient's cyanotic, and so would you take them for a BT shunt and then do a repair later on, or would you repair them with a conduit at that stage?
Okay, so I would do a shunt, let them grow, because if you operate on them when they're small, you are dictated to put a small conduit, and then you have to put another conduit. So putting a BT shunt is not a bad idea. I would definitely do a BT shunt, let them grow a little bit, and then come back when they are at 6 months, when you can put, instead of putting a Contegra that is size 12, or even just doing a back table 8mm graft, you can put a 14. So this is the way that I was trained. Just put the shunt and let them grow. You can do it even at 1 year when they are a bit old. So, I'll show you guys what I mean by double barrel. So this is what I mean by double barrel. So this is if you guys can see the image. So because the coronary is crossing here, you cannot do transannular patch, and if you do just the double patch technique, you will have severe RVOT obstruction. So what you can do is just take conduit, a short conduit, it's not a long conduit, but then the conduit size is based on the age and the weight of the baby. The smaller the baby, the smaller the conduit. The smaller the conduit, the higher likelihood that you're going back within a couple of months. So I would do a BT shunt, basically, if they cannot do a stent in the PDA. Okay, we can listen.
Thank you. Yeah, أنا شكرا أنت.
عفوا. طبعا if you can escape with the double patch technique, that's good and well, perfect. The problem is that these kids with anomalous, right, in the future they will come back to you because they cannot put a melody transcutaneous, because if they put a valve in that annulus, they will stretch the RCA and basically the patient will die on table. So even if you to escape with a double patch technique, you know that these kids will come back to you, which is not a bad thing. Coming back in 3 or 4 years is better than coming back in 6 months with a conduit replaced.
So if no more questions, we can proceed to the questions, to the mock exam.
Any questions? No?
دكتور هاني.
نعم دقيقة بس. شايفين سلايدز بس نعرف هنشوف شيء ولا لا. شايفين سلايد ولا لا؟ امتي سلايد صح؟
ما في شيء دكتور.
يا ما نشوف شيء.
اوكي. بالله بس قولوا لي شايفين السلايدز ولا لا؟
مو أدري مو طالع.
مو طالع هسه.
مو طالع. ايوه نعمل انشير. ايوه اوكي كده شايفين؟
Yes, now we are.
طيب أنا this is trial and error. أحيانا يخبص الكمبيوتر، فقولوا لي إذا حتشوفوا شايفين الكويستشن ولا لا. Okay, so all of you should go to this link up here. شايفين اللينك هذه؟ ممكن تستخدموا جوالاتكم.
دكتور معليش بس اللينك كيف راح؟
فوق POOLLEV.com بعدين / هاني مفتي 557. اوكي الناس بتجاوب كويس. طيب شايفين انكم بتشوفوا number of percentage of people answering. كم عدد البارتيسيبنتس؟ عندنا 12. مين اللي داخل اختبار دحين؟ اسماء الناس. جلال اكيد دخل، انا عارف محمد جلال دخل اختبار. مين غيره؟
فيصل شندين.
عبد العزيز
مين كمان؟
العتيبي.
مين كمان؟
الهنوف العلوله.
فيصل انت من في الرياض صح؟
ايوه صحيح، كينج فيصل.
عبد العزيز برضه رياض؟
ايه في الرياض نعم.
هنوف؟
صحيح من الرياض كمان.
كلكم من الرياض. انتوا بس 4 اللي داخلين اختبار السنه هذه صح؟
صحيح
ان شاء الله.
ان شاء الله توفيق. طيب اوكي so 10 days old child with 4 mm mid-muscular VSD, what's the treatment of choice? So في ناس قالت VSD closure وفي ناس قالت follow up in clinic in 3 months. طيب 83% of you guys are correct. Okay, so the right answer is D. Why? ممكن الشباب. Okay.
It's muscular.
تفضل.
And asymptomatic, nothing mentioned about symptom and heart failure. So patient can have therapy with يعني hopefully it will close by itself.
Okay. Because it's muscular and it's 4 millimeter. You guys remember I said less than 5 millimeter is most likely will close. Less likely compared to an ASD, but still anything less than 5 millimeter will hopefully will close within a year. Right. The next question is شايفين next question المفروض تغير في الجوال عندكم. So an 8 years old child presented with an upper respiratory tract infection to the ER. A murmur was heard. echo showed large 2 by 3 centimeter second MASD, which feature in echo that will determine if they are good candidates for catheter-based closure. So superior rim less than 0.5 centimeter, inferior rim more than 0.5 centimeter, right upper pulmonary vein draining into the right atrium, interrupted IVC. Which feature in the echo will determine if they are a good candidate for catheter-based closure? Please start answering.
The hasn't changed دكتور عندنا.
ما تغير عندي أنا.
عشان ما عملت اكتيفيت. سوري ما مستك. المفروض الحين يتغير. تغير؟ ايوه
تغير الآن.
Okay. I think everyone has answered already. So, superior rim less than 0.5 centimeter, inferior rim more than 0.5 centimeter, right upper pulmonary vein draining into the right atrium, interrupted IVC. So the correct answer is B. Why? أبغى حنوف. ليش inferior rim more than 5 centimeter, more than 5 millimeter is correct?
As you said, Doctor, yesterday in your lecture, the inferior rim is the most important structure to support the device itself. The other answers, which is the right upper pulmonary veins and the interrupted IVCs, are basically contraindications to close with the device because you need to reroute the drainage and everything as well.
Okay. Good.
That's all.
Superior rim less than 0.5. ليش ما هي good or bad يعني? You guys remember from my lecture yesterday, I said superior rim less than 0.5 is a problem, but it's not an absolute contraindication. Some of the interventional guys or girls will say, oh, it's less than 0.5. I don't want to risk it because of the aortic root erosion.
Yeah, erosions and ulcerations.
Yeah. Okay, perfect. So this is good. واضح يا شباب يا بنات؟ أظن أنت بس الحروف الوحيدة اللي موجودة معنا. واضحة الإجابة ليش كده؟ ممكن يعني طبعا don't expect a question in the exam to be يعني straightforward looking for not good candidate. ممكن يجيك سؤال زي كده يخدعك يعني they want you to see if you know the indications to put a catheter based device. طيب the next one activate. Okay, so it should be active now. Let's put it on. What's the most common type of ventricular septal defect? Inlet membranous muscular outlet. I think this is easy. Okay, so all of you guys are correct. Perfect. Jalal, Muhammad, what's the percentage of all VS from all VSDs? What's the number? percentage of membranous?
I think it's around 70 to 80% of isolated VSDs. Yeah.
Of isolated VSDs, yes. Okay. Yeah, most of the time you have a membranous VSD. It's most of the time it's in isolation. Other VSDs are usually with conjugation of other stuff. Right. Okay. Next. Okay. Can you guys see it?
Yes.
Okay. 16 days old baby admitted with symptoms of poor feeding tolerance, diagnosed with intraepid aortic arch. What's the most common associated chromosomal anomaly? This should be very fresh. Okay. Correct is 22q11 deletion. Tabi, what is 22q11 deletion? What's the syndrome?
ديجورج سندروم دكتور.
صح. ممكن مهم تعرفوا الجين ومهم تعرفوا اسم السندروم، عشان ممكن السؤال يكتب لك دايجورج مرفان whatever، فيعني expect انه at least know the common ones. Next. Is old female diagnosed with premium ASD and moderate MR. What is the most likely diagnosis? Ruptured anterior mitral valve chordae, maximatous mitral valve, partial AVSD, shunt complex. This should be straightforward. اوكي خلاص كلكم صح ما شاء الله، مذاكرين او حافظين. طيب اوكي. One day old baby girl prenatal diagnosis of truncus arteriosus, admitted to an ICU and stable condition. Which imaging modality is the best to identify detailed anatomy of the pulmonary arteries? أقول السؤال anatomy. خلاص. Okay. The correct answer is cardiac CT. So I did not ask you guys about shunt physiology. I asked about anatomy. So people will tell in the old generation, yes, they will tell you it's cardiac cath. But you guys have to remember, cardiac cath means you're taking a 1 day old, intubating them, putting them on a cath table, puncturing their femorals. So it's not a simple, straightforward, easy procedure. So CT is easy to be done. So for this question, I'm asking about anatomy or not asking about physiology. If I tell you which imaging modality is best to identify detailed physiology of the pulmonary arteries, then yes, that is the best. But for anatomy only, You need to know where is it coming from. It's from back of the aorta, side of the aorta. One of them is coming descending, one of them is coming and ascending. Then type 4, yani. Then yes, CT is the modality. واضح؟ Okay, next. What's the most common acute complications after arterial switch? Okay, the correct answer is arrhythmia. Pulmonary stenosis is common, but it's not acute. Usually they have a pulmonary stenosis within the first 6 months after the procedure. We were talking about acute post-operatively, like something that will not let you get out of the OR, or something you will find within the first 24 to 48 hours that you have to take them back to the OR. طيب, Faisal, why do they get arrhythmia? And which type of arrhythmia is the most common?
It mainly because of the coronaries or related to myocardial.
Mumtaz, coronary anatomy. Okay, coronary kinking, coronary. Your translocation was a little bit too shallow, too high, too low. Okay, what kind of arrhythmia they usually get?
Ventricular.
ventricular ish.
VTACs.
Yeah, they get VTAC. So a baby, they want within the first 48 hours with VTAC needs to go back to the operating room because the coronary button has a problem. Basically, there's no point of waiting. Oh, this is just hyperkalemia, hypomagnesemia. This is a coronary anatomy issue until proven otherwise. So some places, if the baby is stable, they will take them to the cath lab and inject. But at the end of the day, they will end up on the operating table because one of the coronary buttons has a problem. Okay, next. 42-year-old lady presented with STEMI. Diagnostic cath showed RCA originating from the left coronary cusp. What is the next step in managing this patient? So you do PCI to RCA, cabbage, segment stress test, cardiac CT. اوكي هذا اخر سؤال اظن. لا في سؤال بعد. طيب. Okay, so the correct answer is cabbage. Why do you need a CT? And I'm asking about the management. I'm not asking about the investigation. واحد. Then why do you need a CT? What is it gonna change? This patient will need. She has non-ST elevation MI, so she has ischemia. She needs definitive management. If you send her home, she will have another ischemia and die. And CT will not help you doing anything. The cath will tell you the anatomy, the direction of the. If you're in doubt, CT is not absolutely wrong. But here I'm asking about the management. will you send this patient home? No. She's end-STEMI with an anomalous coronary artery. So she needs definite intervention. What is the definite intervention? PCI cannot be done. There's no point of having treadmill stress test because already she's stressed out and she has troponin leak. And cardiac CT will help you a little bit in the anatomy, but at the end of the day, anyone who's above the age of 25, they will end up with a mammary to their RCA. واضح؟ عشان اغلبكم جاوبوا السؤال ده غلط ف I will spend a little bit of time on it. في شك في doubt.
دكتور ما ادري بس المانجمنت is it always cabbage or مثلا اذا يحتاج بس unroofing للcoronary artery انا انه
RCA are very rarely to be just a slit type. RCA usually it's an intramural course, and usually intramural course, if you do for a 42 years old, it's safer and better to do a cabbage and forget about it. If you do unroofing is mainly for someone who is in their mid-teens that you don't want to do a cabbage now, and 15 years or 16 years old. But for RCA, it's usually a very long intramural course. Cabbage is the safest approach. في الاختبار ما حد I will not come to you and ask you, oh, how do you do unroofing? Safe is cabbage. Forget about it.
Okay.
But you're right. If they're young, 15 years old, I'll do حرام أحط له memory دحين بعدين بعد 10 15 سنة 20 سنة we need another surgery. I'll save the memory for later on. But for 25 to 30 years old, just put a cabbage and put a good arterial conduit and forget about it.
طيب Dr. Hani, if the patient or basically if this question says like a 15 or a 12-year-old female, would you go ahead with a CT to further analyze the anatomy or root of the RCA itself, or would you go ahead and take for the surgery and intra-op decide what to do?
If the question says what is the next step in diagnostic modality, then yes, CT. If the management is the same, it doesn't change. The management is surgical intervention. What is the this was 15 years old, I wouldn't say cabbage. I would say cabbage, coronary unroofing, coronary translocation, watch and see. Basically, that's what I would say for management. For investigations, we're not trying to trick you guys. We're asking you what is the management here? What is the investigation? At least when I write my questions, I say what is the next best imaging modality to identify the root of the anatomy of the RCA. But when I ask about management, I want the definitive management. What is the treatment? And then we're talking about 10 years old to 20 years old. I have to give you more information. صراحة عشان to which surgical modality. If I have a 10 years old with a slit-like RCA coming from the left, next to the left, not translocatable, I will say more information. And no one will ask you about صراحة translocation or unroofing, because this is a pure congenital thing. But yes, you're right. If I ask you about investigation, then yes. I can ask this question a different way. 25 years old, healthy, comes with intermittent chest pain for the last 6 months. Undergo echo. Echo shows abnormal flow in the RCA. What is the next test or what's the next investigation of choice to identify the origin of ischemia? I can say echo stress test, cardiac CT, cardiac cath, troponin. So which one is it? Again, she has mild symptoms, vague symptoms, and then echo showed abnormal flow in the RCA. ما حد قال لك it's abnormal origin ولا شيء. Think of her as what?
She's young, so I would go with a CT, cardiac CT, and it would not
CT.
I prefer angio.
Yeah. Yes, exactly. So CT. But if I say she's 25 years old, known case of abnormal origin of the RCA, would you do CT دحين? But she has no symptoms. or vague symptoms?
No, actually, the ultimate intervention will be surgical intervention because I already know that she has.
I'm asking what investigations the height. She's known to have abnormalist origin of the right coronary artery. She has mild symptoms, vague symptoms, chest pain on severe exertion, no history of arrhythmia. What is the next investigation of choice to identify her risk of ischemia? Cardiac CT, cardiac MRI, coronary cath, stress test.
Stress test.
Yeah, stress test. Now I'm asking you, is she at risk of having sudden death or not? So now I want to document, have some objective, حتى لو CT طلعني إنه عندها coronary artery coming from the right. What I cannot take her to the OR. I have no objective reason to take her to the OR. But if she has stress test, she has VT. طبعا الستريس test for anomalous coronary artery is different. مع البروس بروتوكول ده أي كلام ما يمشوا عليه. في different protocol في anomalous coronaries. Once they have arrhythmia, any kind of arrhythmia, AFib, VTAC, SVT, أي حاجة, they are at risk of ischemia. You stop the protocol once they start having either severe chest pain or change in their P wave, ST segment or arrhythmia. شايف في السؤال ممكن يتسأل in 3 different ways and you have 3 different answers.
Dr. Hani, is it safe though to do a stress test in a malignant course while I know it's a malignant course, even though the patient is asymptomatic?
Yes, it's safe. You have to do it. You have to document it. You cannot take them to the OR without documenting ischemia, even if you know it's a malignant course. طبعا knowing it's a malignant course will stress you out, but they will not. They usually don't die from arrhythmia. They die from sudden if they are in a controlled setting, they recover. That's why you have to do it in the hospital. ما تسويه في الشارع. What kills L kappa and a malignant anomalous coronaries is that they have stress and they arrest in the field, and then whatever CPR you do is not effective. They need electrical shock. But again, حتى لو طالعوا في الالجوريثم اللي حطه دكتور ماثيو, you have to document that they have ischemia, especially RCA coming from the left. LCS coming from the right is a different story. Once they have ischemia, once they have any symptoms, they have to be operated on. But RCA from the right, from the left is the one that is a bit difficult to manage. You cannot justify operating on them if they have no symptoms, because the operation is risky and the outcome is very, very small. The benefit is very small. Okay.
Yes, okay.
حتى في CT, you cannot tell if it's malignant or not. Sometimes you do a CT, and based on the phase of the CT, you see that the artery is wide open. And you take them to the cath lab, and you do increase their heart rate, you give them adenosine or something, and you can see that they have it's an intramural bridge. Basically, the vessel occludes in diastole and distends in systole. Right? CT it's good, but it's not the gold standard treatment, the modality. But it's the first thing to do. Last question is the last question. What's the most common arrhythmia after complete repair of the tetralogy of Fallot? Supraventricular tachycardia, complete heart block, ventricular fibrillation, junction of ectopic tachycardia. Yes, all of you guys are correct. And SVT is very rare in children, very, very rare. Complete heart block, basically you did something very bad. VF is very rare in children. They usually have asystole more than VF. Jet is the most common arrhythmia. Any congenital anomaly question that has arrhythmia, Jet is the first one to remember. And you guys need to know how to manage Jet. is that for the people who are sitting the exam this year, you need to know how to manage jet. So, Hanoof, what's the treatment of jet?
You can treat by cooling.
حلو ممتاز. Cooling one.
Second, amiodarone.
قبل الاميدرون في حاجة ثانية نسويها. So you cool. How much do you cool?
32.
لا 32 البيبي will arrest عليك في الاي سي يو. لا كم يعني انت
34
normal temperature is 36 برضه كثير 34 يعني 35 is 34 you're يعني a little bit شوية. You have to remember يعني these are new names يعني cooling them to 34 will have platelet dysfunction يعني ايش arrhythmias you induce arrhythmias by cooling. So يعني most the teaching will tell you 35 cool down to 35. طيب if you cool and they're still in fast jet what you can do before medication. You did open heart surgery في
overdrive.
ايوه overdrive based them. اوكي طيب كويس. and there is a way to do it مش ضروري تعرفه كيف بس يعني there is a special technique to do overdrive pacing. بعدين medication amiodarone yes congenital يعني we try to avoid amiodarone as much as we can because of the thyroid dysfunction that's caused it. But يعني if you have to use it you have to use it. طيب if amiodarone cooling overdrive pacing that did not work what can you do? And the baby is unstable.
We can use like I don't know if it works in babies or not, but Esmolol is also another choice if amiodarone fails in jet and overpacing fails as well.
Yes, so that's actually the first choice is Esmolol before amiodarone, but it depends on the comfort of the ICU team also. Esmolol is much better because it's much shorter acting, so and it does not affect your pacing as much. If you have amiodarone and pacing, it affects each other. So Esmolol is the best choice. Type غيره is if you all of this fails and the baby is still unstable.
If he's unstable, ECMO.
لا قبل ECMO ما باك تفتح صدر البيبي. هتفتح صدره على جت مصيبة.
كلم الاي بي.
to put them on ECMO. لا تكلم الاي بي يا عمي سوي في شيء تقدر تسويه. يعني it's an arrhythmia and the baby is unstable. What can you do? You have pacing wires and it's not.
Cardioversion.
شكرا. Cardioversion. يعني you try to, طبعا the risk of going into a bad arrhythmia is there, but that's why you have pacing wires. So the algorithm for treatment of jet is cooling. First treat the problem because they're most likely in jet because of stress. So if they are awake, if they are in pain, if they are not sedated well, then you sedate them, must relax them, try to take the metabolic demand out of them. If this all does not take it away or slows them down, then you cool them. If you cool them and it doesn't go away, then you start some medication. If the medication doesn't work, you put them on Esmolol, and like within the first 5 minutes of bolus of Esmolol, they're still fast. Then you can either add amiodarone, which takes at least 30 minutes to work in children, or you just cardivert them. So cardiverting them, basically you have to make sure that the pacing wire is working because they can go from jet to VT, and from VT you have to shock them, and then you have to pace them. That's it. You guys have to know, especially الناس اللي داخل اختبار, they have to know how to manage jet because this is a very common post congenital heart surgery complication. Okay, thank you very much. I think that's it for the day. خلصنا 10 دقائق قبل الوقت. Any questions? Hello?
No questions.
No questions, Doctor. Thank you very much.
ثانك يو دكتور.
يعطيكم العافية. شكرا.
Thank you very much,
يعطيكم العافية.
Dr.
نراكم الأسبوع القادم. If anyone has any questions in between يعني من الأسبوع الجاي يعني كان مدري ايميل مي تكست مي كول مي. اوكي الأسبوع الجاي الشباب والهنوف هتكونوا تحت المجهر شوية. طيب شكرا. مع السلامة. في أمان الله.